Hi guys, this is Alicia with Good Morning Sunshine. So today is Friday, yay. We had integrative session this morning where we come in groups. I'm D group, but there's A, B, and C group. But first we take an hour, we go through stations, and then we all come together as a big old class of 126 of us. But usually we're giving a scenario, and then we do stations based off that scenario and try to get to like a conclusion of what's wrong with an animal. So this week we had Mo, which is a 10-year-old quarter horse gelding. He presented to us with intermittent lameness that has come and gone repeatedly over the last 2 years. So in our pre-lab assignment, we had to read an article, and it just explains like a physical exam and lameness exam for a horse. And then we had to evaluate radiographs that were taken of Mo's foot. I was gonna see if I had the notes for the article. I know I took them. Here we go. So lameness being any alternation of a horse's gait. It can manifest in either a change in attitude or a change in performance. So the essential features of a lameness evaluation include medical history. It includes a visual appraisal of the horse at rest. It includes a hands-on with palpation. We have the application of hoof testers. We have the evaluation of the horse in motion. And then we have joint flexion tests. And then we also get into diagnostic tests, which include nerve and joint blocks, radiograph, sonography, which is nuclear scanning, or ultrasound, or arthroscopy, or blood, synovial, joint fluid, and tissue samples. So there is a lameness scale that is 0 to 5, 0 being no lameness, not perceptible under any circumstances, and then 1 includes lameness difficult to observe and not consistently apparent. Then we have 2, which is lameness difficult to observe at a walk or trot, but consistently apparent under certain circumstances. And then 3 is lameness consistently observable at a trot under all circumstances. 4 being lameness obvious when the horse is walking. And then 5 being minimal weight bearing in motion or at rest, or the inability to move at all. So the most important question to ask is, what will you be doing with the horse? So then your vet will make considerations based on the type and level of performance that you expect out of your animal. We assist in finding current or potential problems. In the lameness evaluation, there's 2 things to determine. Is the horse lame at present time, or are there existing conditions that we should look at? And then the next question being, what is the likelihood the horse will remain serviceable for its intended use by owner? We, as vets, we will provide, when I become a vet, we will provide facts and risks, and then the owner decides what to do with these. So there are limitations to purchase exams, 1 being conformation, 2nd being hoof care, 3rd being use of protective leg gear. There's fitting and conditioning of the horse, degree and manner of training, type and level of performance, age, skill, balance, and experience of the rider, type or condition of the ground on which the horse performs, disease and injury, genetic predisposition, and there are many other things that could limit our interpretation. So that was what the article was on. And then, again, I gave you the scenario that we were given about Mo. We were given more stuff. So Mo is a quarter horse gelding, like I said. His owner is 16 years old, and in the past has used him for limited competition at the local level. About 2 years ago, he would occasionally show lameness, so the competition pretty much stopped at that point. He's still used for low-level trail riding on occasion, which both he and his owner enjoy. And then the lameness has now returned at various times and now seems to be recurring more frequently. So in our first station, we were focusing on general anatomy and relationship to clinical findings. So here's our numbers. We had to list what the hoof was. So number 1 being the hoof. We had to name carpal joints, which would be number 5. And then the pastern joint is number 2. And then we have the fetlock joint, which is 3. We have the cannon bone, which is 4. And then we have the splint bones, which are in 4. They include carpal bones. And then we have the coffin bone, which is 1, which is the 3rd phalanx. And then we have the navicular bone, which is also kind of in here, which is in 1. And then we have the long pastern bone, which is 4. And then we have the short pastern bone as well. So then I can show you also what hoof testers are. So they're basically a pair of pliers. And the goal is to put pressure on structures deep in the hoof of a horse in order to assess for pain production. So here you can see them using the hoof testers, which they would use on the coffin bone and the navicular bone. So Mo has a palpable swelling in the area indicated by the arrow, which I'm going to show you in a minute. Right here by the arrow, and that is the pastern joint, and he has swelling there. So then in the second station, we were given radiographs, which we had to indicate what radiograph was taken and like what view the radiographs were. So of course we were given 4 radiographs, and then we had to list like, were they lateral or... So this one would be lateral. This one is DP, which means dorsopalmar. And then this one being dorso 65-degree proximal palmaro-distal oblique. And then the last one being palmar proximal palmar distal oblique. So they were different, taken at different angles in order to see different bones, because some bones you didn't want superimposed over. And then we were given the radiographs of Mo. We are given a regular this one right here, those are Mo's radiographs, and this one over here, these are normal radiographs, and then we were asked to compare. So I don't know if you see the letters, but A on this side is the long pastern bone, which is also known as the first phalanx. B is the short pastern bone, also known as the second phalanx, and then C being the coffin bone, which is also called the third phalanx. So we had to explain what we saw in the radiographs. There was definitely inflammation of the pastern bone, causing the breakdown of cartilage. There was new bone production on the short pastern bone, which we could see, which is known as osteophytitis or something like that. But anyways, it's when osteophytes are in the area of the joint. And then our last station, we were doing a comparative aspects of anatomy. So we were just given structures of the carpal joints, the metacarpal, and the phalanges. And we just had to name which colors went with what. So of course first we have the carpal bones, which are these bigger bones. And then we have the metacarpals, which are the tiny ones and like the wrist. And then of course we have the phalanges. So the first one being sheep and goat limb, the next one being a cow, and then this one being a horse. Sorry. This is human. This is a cat. I'm like, why don't these look weird? This is a human, this is the cat, this is the dog. And then we have here we go. We have the sheep goat limb, and then we have the cow limb, and then of course the horse, because that definitely looks like a horse limb. Sorry, I wasn't really looking at the pictures when I was telling you guys. But those are all the limbs. And then of course we had Neurobiology. He had a few slides to go over, but I wasn't gonna go over that, but I will look at it for you. Because it's already almost 9 o'clock here, so I can explain the end of neurobiology tomorrow. I hope you guys will have a good weekend. I will also talk to you guys tomorrow. But it's Friday, and hopefully you have a good Friday night. And I'm gonna work on some work again, to hopefully get one of my assignments done for becoming a veterinary professional, which is one of our classes. We also had that today and learned about preventive care, which we already walk dogs and do all of that, so I don't know why they went over it today when we were already thrown into it and had to figure out what we were doing. So, but yeah, I love you guys and thank you guys for watching.